Hey everybody, I'm Nina Crowley. I'm Seeka's Professional Affiliations and Education Manager, and I'm excited to be here today with a friend and colleague, Kara Horn, who is the Metabolic and Bariatric Surgery Coordinator right now for Bayfront Health in St. Petersburg, Florida. And she just moved over from University of Oklahoma, where she was the coordinator. So I'm excited to talk about some of your background and experience, and thanks for being on with me today.
Yeah, thanks for the invite. I'm excited.
So I started thinking I wanted to chat with you, and we just saw you went through one of the very complex and time-consuming bariatric center accreditation site visits. So I understand you guys had the first in-person visit since COVID. And as a bariatric program coordinator myself, I had been through two. One was in person pre-COVID, one was post-COVID virtual. So I know how intense those can be. So tell me a little bit about your experience with that.
Right. This is my second, and it was kind of flipped. So the first one I did was virtual, and this was in person. And it was new for everybody. So, a brand new site here. And Dr. Scott hadn't done an in person in a long time either. So, we kind of walked through it together. It was nerve wracking because in the virtual, right, you know what they're seeing because you're taking the picture, you're presenting everything. So it was really neat to see the entire interdisciplinary team within the facility come out excited about bariatric care, excited about being able to provide this treatment option for the population and tell stories. And it was a neat experience, honestly. And then even afterwards, like some of my staff reached out and wanted to see if they could reach out to Dr. Scott and tell him how some of the stories he shared really touched them. So it was very neat. That personal piece doesn't really happen in the virtual environment. So it was a really great experience. I hope we're still waiting on the final result. So
Okay. Yeah, I love the site visit because I mean I know, for people who have not gone through that metabolic and bariatric surgery quality improvement program, MBSA QIP, a long acronym there. They do the accreditation for bariatric centers of excellence, it used to be called, and now this is accredited programs, comprehensive programs, and they undergo, I think it was an 89-page manual of standards that you have to show how you're following. And so this is really what we have in this field for making sure we have a good standard of care, making sure your hospital and your facility and all your areas are set up for taking care of patients with obesity. And I always remember taking pictures of every single toilet in our facility to make sure that was the
right.
right floor mount and the right weight limits and all of that. So it's comprehensive, and they make sure that you have all the things you need from a organizational perspective, buy-in from the organization, all the clinical pathways, and like you said, interdisciplinary team. And so I started thinking a little bit about how intense this process is, and how we are seeing a lot more centers that are including not just the bariatric or the surgical component, the
Mhm.
metabolic or surgical component to the pathway, but also starting to include the medical component. So in 2019, they added you could become a surgical center with obesity medicine designation. And so my center was not when I was going through that. So I was curious to hear, you guys went through this with the obesity medicine designation. I think it's really interesting because we are seeing so much more collaboration among medical and surgical arms where they used to be a lot more siloed. So I like that they have this accreditation process. But tell me a little bit about how you're structuring your program and how that went.
Right. So we brought on an obesity medicine. Well, our surgeon is a co-director for the surgical and the obesity medicine piece. But our obesity medicine piece is really run by our nurse practitioner who has done all of the obesity medicine training that physicians typically do. So she'll have a certificate versus that board certification.
Okay.
All of our patients see her and the surgeon jointly at their first visit. And what we found is it's really kind of a reciprocal type of program. It doesn't have to be one or the other, nor should it be. Some patients maybe come in and surgery is a lot for them to take in. They're not ready for that. But medicine is kind of that softer approach, and they want to try that. And some people do fantastic with it. And then some people will turn around and decide they're going to go ahead and go surgical, or some people come in wanting surgery and then they can transition back. So either way, you're building your practice, you're building your clinic and your reputation kind of around the community, right? So it's not here any type of competitive piece to the program. It's an integral piece to the program. So whether or not they're getting surgery, they go through the same path. They're going to see our obesity medicine specialists. We're going to look through their medications. We're going to do labs. They'll see our dietitian. Our psychologist and sports medicine team also sees every single patient that goes through the program. We are getting our first body comp analyzer today, hopefully. Super excited about that. And so then we can actually incorporate that as well, both in obesity medicine and in surgery, so that we can help our patients see what that composition change is happening. It's not about the scale. It's not just that gravity, right? What's happening inside their body, so that our whole team, right, can target the treatment that they're having, that then our dietitian can have more structured treatment plans for the patient. And that's whether it's the medical or surgical piece. That's the whole point, is targeting a treatment plan to that patient. There's no black and white, one size fits all for anyone. So we're excited about the medicine piece. And I think that we'll start seeing most programs, honestly, my prediction, go in that direction in the future, is even after surgery, right? We're seeing that medicine piece is a great adjuvant therapy to keep treating that disease, because the chronic disease doesn't go away because we have surgery. So obesity medicine is an exciting field that's going to grow, I think.
I love that. And I think, to me, what I'm hearing the most is that continuity of care, right? So if you're the patient coming in, you want to be taken care of by this group, and you build relationships with people. And so I love that, whether or not they're taking this or that treatment, we know that's not a bucket of, either or anymore. And so they're getting to know that same team. So your dietitians, I love that you're using, you said sports medicine department is seeing them.
We've got two medical doctors, two MDs, and an athletic trainer that they see. And so they'll see the medical doctor the first time, and it's like an hour and a half visit. I mean, they go through everything, pretty an intense workup. And then they target, again, the specific exercise plan, treatment plan to this patient. What can you do? Like, do you have any specific limitations? Because a lot of our patients come in thinking, well, I can't exercise because my back hurts, because my knee hurts, because whatever. But they're able to see, what it is that their limitation is, and then build an exercise prescription around that, showing them you can still be fit. You can build your body in ways that you like. What do you like to do? What do you have access to? And so it's been a really neat process watching them. And then our athletic trainer follows up with them a couple weeks later to see how that's going. And then we bring them back again second time in office pre-op, and then they can follow post-op as well. And our team doesn't discriminate as far as insurance goes. If their insurance doesn't cover sports medicine, they're going to see them anyway as a part of our program, which I think is really special.
Definitely. I mean, I know when I was a coordinator, we struggled to sort of figure out how to make that work. And, do you use the physical therapy department? Do you connect them with local gyms? I felt like the exercise component was not our strong suit. And then as the dietitian for years, it was always, since we didn't have that, clinical person tackling that per se, we ended up having to talk to them a lot about that. And it wasn't top of mind. It wasn't the focus of our session. So it kind of did sort of fall to the wayside. So I love that they're a real strong component. And I think, they're probably going to get a lot of use out of body composition assessment too, for targeting what they do. That's really exciting.
Right, 100%. And they work very much in conjunction with our dietitian too, right? Because as our patients are building their fitness and exercising more, then that diet has to change. So again, personalized treatment, right? So we'll have patients come in and they're like, oh my gosh, I'm feeling tired, or I feel jittery, or I feel whatever. Well, are you exercising more? Yes. Well, then we need to look at that. So having that, we have a Berry board that everyone gets together at, once a month. We can talk about those things and alert the dietitian, hey, when this patient comes back, this is their exercise plan. So they can kind of build that education in, because a lot of them are scared of carbs, or they're, mostly scared of carbs. And other things, but if you're exercising, you need those things. So it's interdisciplinary collaboration is just crucial, I think, to the best patient plan. Yeah.
That's really great. I do miss my team in that regard as you're talking
Yeah.
about it that way too, in our monthly meetings and talking about patients that way. And I think a lot about, I've been talking just so much more to obesity medicine folks who are getting, their programs starting up. They're working on assembling their team and trying to figure out what's the best model to do that. I think there's not one, not a one size fits all or best model, but I
Hmm.
do really appreciate kind of the surgical arm has been well developed for years, right? So, I mean, we've
Right.
had accreditation since 2006, is it, with the Bolt database? And then we had 2013, I think, is when MBSA Quip came around. So, really kind of ensuring this standards that everyone meets. And so I'm glad to see more centers doing the obesity medicine piece. Are you
Hmm.
guys the only ones in your area that do that?
So I was real
Yeah.
excited when we had our certification, our survey, because I was like, I haven't heard about anybody else. Of course, there's med spas on every corner, but being able to be, accredited in that way, where we feel like, we're providing the safest, care for these patients. So I looked. There is one other Tampa General that's in the 250-mile radius. So two of us that'll have that certification. Yeah,
Well, good. I mean, still not enough to take care of everybody, but I
gosh,
think
yeah,
there's so much that the medical team can learn from what has worked with the surgical team, right? I mean, as far
absolutely.
as weight goes long term, these are patients that are going to be our patients for life, and we've really, I think, got that into everybody's mindset from a staff and a patient perspective. Like, you're our lifetime patient, and so it's not just temporary, it's not just the first year or two post surgery. It's, we're going to take care of you for the long term, and I think that's important. I know that's part of the surgical programs, and I'm hoping that we see that be more part of these medical programs. Like you said, there's a lot of entrepreneurial stuff going on because the medication has a different vibe and a different payment model than surgery, where it's like, you've got this discrete event and then that dictates all this wraparound care for life. That aftercare, we know, is really critical to their long-term success. I would always
Absolutely.
say that to our surgeons. Like, they have a really important job, but then the rest of the team kind of kicks in, and that's really where a lot of that long-term relationship is managed.
Right, right, absolutely. And that, I feel like that long term care is what's lacking in a lot of the places that aren't these comprehensive centers, right? Because
Mhm.
that mindset is that obesity is weight, and it's not the same thing, right? So if someone gets that weight down and thinks they're good, that weight's just going to come right back on, as opposed to we're treating a chronic disease. We need you to keep coming back, and we can keep honing that and making sure that the treatment that you're using consistently and intentionally continues to treat that disease process. And it's something that's not going to go away. And if patients and I think the general public don't grasp that piece, that this is a comprehensive long-term event, not just a surgical event, that's where we're seeing so many, like, a rise in revisions, and the need to kind of combat that weight recurrence and things like that. So I'm hoping that as these obesity medicine centers open and grow, that quality piece of MIPSQUIP, which is my favorite piece, really kicks in on the obesity side as well,
Mhm.
so that we can continue to not just be accredited in quality center, but a piece of that is that every year we're looking, we're focusing, we're honing and getting better and working, striving for better patient long-term outcomes versus just that first 30 days or first year.
I love what you said too, that the focus on quality needs to be the most important, because that
Right.
that really is what this is all about. I mean, you've been in the field a long time, like I have, and when I joined in 2007, surgery was really, effective, and the numbers had gotten really good as far as, outcomes and all of that. But it's that there still was that public perception that it was super dangerous, and then we've seen these centers be able to put out their data and say, the risk of having, I don't remember the statistic, but I think it's like the risk of getting your gallbladder out might be even more risky for 30-day mortality than having bariatric surgery, right?
Right.
And so that kind of data comes out of these quality programs. And so I love that we're including that in the medical space as well. And I know I didn't know the nitty gritty of the details for the medicine requirements, but it sounds like you embedded that into a clinical pathway. And then what kind of data are you collecting on patients who have the medical route?
Right. So it's very similar data, quite honestly. The one thing that's added is that body fat percentage change from the surgical side to the obesity medicine side. But beyond that, those variables include, overall weight change, comorbidity resolution, body fat change, the medications that they're on, anti-obesity medications, and are they having any side effects? So they're also kind of tracking that, how patients are responding, to the medication side. But then when they follow up, we're expected to collect labs, have them see the dietitian, so have that nutrition education. Again, we add the psychological component in sports medicine. But for MIPSQUIP specifically for that accreditation, it's that body fat change, total body weight change, comorbidity change, the medication they're on, and side effects, so any outcomes there.
Yeah, I think the behavioral component and that exercise component are so important as well. And I don't see that as much. I mean, I do see dietitian support for a lot of the medication programs, some of the virtual only programs, but I'm not seeing as much of that psychological or behavioral support as well as exercise. And those are both key components of the medical treatment being successful long term
Right.
as well. Yeah. And the behavioral piece, I think there's always with surgery, there's always been this kind of, is this to regulate care? Is this to get people, not to have surgery? And in my experience, it was a lot more about readiness than it was about yes or no. So it was much more that gray area of, we're not saying, there's very few instances where the person's not at all a candidate, it just might not be a right now. So do you find do you have the behavioral folks seeing the patients before they start medication or just kind of embedded throughout the process?
So the piece that kind of stops their ability to start medication, right? They have to have their labs drawn, make sure that there's nothing there. We do an EKG and they see the dietitian. And at that point, they're able to start. Beyond that, sports medicine and psych is something that we encourage, but we won't withhold medication unless, there are certain patients, right? You look at and you look at their history and right, you're like, yeah, we need you to start here. But as a whole, the psych and sports medicine piece are recommendations. I just got an email. You saw me looking at my phone. Our scale just arrived, so I'm very excited.
Oh wow! Okay.
Come from delivery.
Well, we didn't plan that, but I'm excited to hear that. And I know, you're a fan. I know when we talked last, when you were in Oklahoma, you had just worked on the process of getting the body composition device into your center there, but had to leave before it arrived. So I'm excited.
So it was like a year and a half process going through all of the approvals and all the things. And I think it arrived the week after I left.
Well, we'll have to touch back after you get it and are using it. And I'd love to hear, how it's working with both arms of your program as well.
Yeah, absolutely. Every member of the team is super excited to have this piece so that, we can show our patients like how their body's changing and then again, target their treatment plan to that. So super excited. We talked it up last night, even in group, we're in support group. We're like, come back. This is supposed to come tomorrow. And, we'll get these measurements started for you because we're all excited to have that baseline. Everyone's already, on their own path. That trajectory's already started, but everyone's thrilled. Yeah.
Will you have it at the support group itself or?
So we actually have our group in the lobby area. So they can just come back kind of around the corner and
Nice. Well, I miss my support groups. I thought that was a really important component of the surgical programs. And I do hope they're continuing. People sort of moved to this virtual space and I never felt like it was the same as these, really they were just so good, the conversations and the connections that were made in support group. And I just think that was such a critical component of many people's long-term success plan.
Absolutely. I mean, I think there's a space for both, but there's just something about being face to face, like seeing the people and they feed off each other. Less likely, they're more engaged, right? Less likely to be like, yeah, well, I don't want to. What if I unmute and someone unmutes at the same time? And there's that awkward space. Whereas if you're all in the same room, I feel like we get better, more enthusiastic conversation, and yeah, it's great. I'm thankful that we're in a place that we're able to do that.
That's awesome.
Yeah.
Well, yeah. Well, let me know when you get your device up and running, and we'll connect again and make sure that we're checking in on how the progress is going, and hopefully I'll see you at our next bariatric meeting, June maybe, right?
Absolutely. San Diego.
The annual meeting. I can't wait.
Yeah, super exciting.
All right. Well, thank you, Kara. I'll talk to you soon.
Yeah, thanks, Nina. Have a great day.